Thank you, chairpersons, and thank you, West Bengal Echo, for this very kind invitation. And this was actually meant for the younger audience, so I go through some basics. So we have this interesting case, and case summaries are how we all learn and move ahead. So this is a 36-year-old male. He presents with progressive shortness of breath for nearly 1 year with vague chest discomfort. His risk factors include his being a smoker, he's non-diabetic and normotensive. And we also have his echo parameters. The LV is dilated, there is borderline LA dimension, and the most important thing is we have an EF, which is 33%, a mild to moderate mitral regurgitation, and a pulmonary artery systolic pressure of 40, with the RA and RP being normal. So this is the short case that we have been given, and let us just dissect it and move ahead and see what we can find. So I think the most important thing in any kind of clinical presentation is to dissect those salient points which is going to help you with both the diagnosis, treatment and the management. So we have a 36-year-old male. He's a young person, male. The predominant symptom for this particular patient is shortness of breath. That seems to be a very important part of his clinical presentation, which is progressive over the last couple of months. And the chest pain, for whatever reason, has not been given importance, and we will possibly play this a little below, and the shortness of breath being the more important symptom. He obviously has a cardiovascular risk factor despite his young age, so that he's a smoker, he's an active smoker. And a very important clinical point is we have an echo, and the EF is 33%, or as we say, less than 40, and he comes under the HFrEF category. So we do believe that this is a heart failure patient, and we know that heart failure is an important problem. It is a big epidemic in our country, and because of the risk factors like hypertension, diabetes and smoking, which are drivers, the incidence keeps increasing. Now what is important here is that heart failure in India is a little different from what heart failure is in the Western world. And one of the important things is it comes in very young. We must believe that rheumatic heart disease, although most of us are not seeing too many these days, is an important etiology. And of course, there's a male predominance in this whole story. And the risk factors like diabetes is also driving this younger epidemic. So let us look at the diagnostic approach to this patient, now that we know that he has a reduced ejection fraction. And when you look at the whole story, you will see that the males predominate in the ref region, whereas in HFpEF it is more a female predominance. And the HFpEF incidence is also increasing in our country because of the use of BNP and echocardiography. So a little throwback on the pathophysiology, and you'll know that we did learn about the heart failure as a forward versus backward failure, not very pertinent today, but the essential pathophysiology remains the same, that there is a neurohumoral activation, there is a renin-angiotensin activation with aldosterone excess, and that causes the salt retention. The sympathetic system gets activated, there is vasoconstriction, and this whole milieu leads to both the forward and backward failure, and this is an endless loop which causes progressive deterioration of the left ventricular function. Now when you look at the symptoms of this patient, dyspnea seems to be the hallmark of his symptom, and the other symptoms that usually go along with it is fatigue, swelling, edema, orthopnea and PND in the extreme case. What is also something that we have seen and is very particular in India, especially with the women at home, is bendopnea. Is whenever they bend to do housework, they get breathless, but they're otherwise comfortable. So an important eliciting history here is to get that history, especially if you have a sedentary person, and you will find that it is present. So when we look at the findings now, when this patient comes to us, there are respiratory findings which include the crepitations, rales, but also there is a possibility of you getting a wheeze. And this is not something which is an intrabronchial problem, but it's because of the edema compressing. There is an expiratory wheeze which is sometimes mistaken in peripheral setups that this patient has a chronic obstructive pulmonary disease or a bronchial asthma, and the treatment completely goes over. Pleural effusion again is an important thing, and X-ray and lung ultrasound can pick these things up, which may be subtle parts of heart failure. There are abdominal signs as well, and sometimes patients with right-sided heart failures can develop more of an abdominal symptom. We talked about bendopnea rather than sort of lung symptoms. So patients with liver pulsations, tender hepatomegaly, ascites all have to be looked for, and if there is a doubt, a quick ultrasound also has to be done to make sure you're not missing the ascites. Central to the heart, obviously, are the important vital parameters that have to be documented. Sinus tachycardia itself is one of the first signs of heart failure, including a displaced apex, S3 gallop, which we are good at examining, and of course a shift of the impulse and a parasternal heave if it is a right-sided failure. So when you put all the clinical features together, the elevated JVP, the apical impulse, the RALS, edema, and ascites fit together, and you get the clinical syndrome of heart failure, which we know is not a biochemical or an echo diagnosis, but it is a clinical diagnosis of heart failure which you need to make. Once you make that diagnosis, then you move to what is the NYHA classification. Although dynamic is a very important point where medication and intervention start mattering. So we have the 1 to 4 NYHA class, and this patient appears to be between 2 and 3, and we know that patients with 4 would be possibly people coming in for admission. Once the clinical diagnosis is made, then you want to see at which stage of heart failure, and once you have a clinical syndrome of heart failure, he straight away goes to the American College stage C, or symptomatic heart failure, in which most of the drugs and therapies seems to work. Stage A and B obviously are patients who would have been seen much before their clinical syndrome of heart failure, and those interventions would obviously be different. Once you got everything together, then we look at the European heart guidelines of what is the EF of this patient, and based on that he would be divided into either a HFrEF, a HFMF, or a HFpEF, which is more than 50, less than 40, and the HFMF would be somewhere in between 40 and 49. And these are patients who are obviously either migrating between HFrEF to HFpEF, or patients who actually worsened if their HFpEF is not recognized. So what the European Society has done is take the ejection fraction, add the BNP levels, and add at least one additional criteria, which would be an echo criteria for left ventricular function or left atrial enlargement, and the diastolic parameters, whatever is there, with or without the GLS, to make that complete story. So if you look at the diagnostic algorithm, the most important thing here is the clinical story that we talked about. Physical examination, clinical story together, making the clinical syndrome of heart failure. And once you do that, you do the ECG and the labs. The labs here, the most pertinent would be the renal parameters and the hematological parameters to make sure you're not missing anemia, CKD, hypothyroidism. Once that is done, then you would go to the natriuretic peptide, and we use NT-proBNP because we are using a lot of ARNI in our practice today. So we don't use BNP, we're using NT-proBNP, and the number that is given is 125 or more. And once that is positive, the transthoracic echo becomes then the most important tool to look not only at the ejection fraction, which is central to how we manage these patients, but as was already discussed, the various other causes of heart failure which we will come to. And once that is done and you put this patient in a specific basket of HFrEF or HFpEF, then you would do more advanced techniques and advanced imaging. So all these tests have a certain level, and the BNP 12-lead ECG echo has a very high class 1 level of evidence, including the blood tests. And so these are important parts when you're evaluating a patient with heart failure, and these are now mandatory. The Association of Physicians of India have not been far behind, and they too follow a very similar pattern of history, examination, investigations, and confirmatory. And for those of us who do not use NT-proBNP in the peripherals, then echo becomes a very important tool, and it's a central tool for making the diagnosis and putting that patient into a specific category. And when you look at all the three guidelines, both the American College, the European Society, and the Cardiology Society of India, more or less are in sync with making the diagnosis of heart failure clinically using the NT-proBNP echocardiogram. And then, because in our country ischemic heart disease is so prevalent and such a big driver, a coronary angiogram. So the lab test we discussed, the central point would be the BNP, a complete blood count for anemia, electrolytes to look at the kidney issues, as well as any complication of therapy, and liver function, especially if there's a right-sided failure or a chronic congestion to the liver, you could make that out. Now the ECG again forms a very important central point of this patient, and four important things that we need to do is to look at the QRS duration, look at whether the patient has a left bundle branch block, because that could have a very important prognosis if it is more than 150, and also could help us choose a therapy like a CRTD for these patients who are not responding to medical therapy. Left ventricular hypertrophy and atrial fibrillation, again a very important point where you would like to add a NOAC in these patients going along. Now, as I said before, echocardiography is a very important point. It's the hallmark of heart failure. So the ejection fraction, the dimensions, the wall motion, valvular abnormalities, either primary or secondary. We did mention that rheumatic heart disease also is a very important part of heart failure in the young. And most importantly, when we're looking at a HFpEF patient, the diastolic parameters become very, very important. Now, additional imaging studies like the X-ray, which is the only study which will look at the lung congestion or the lung vasculature, is very important. And it's very important to look at that lung X-ray before you move ahead. I will talk a little detail on the cardiac MR and nuclear techniques. Suffice to say that these techniques follow after the essential investigations are done, and echo gives you a certain direction point as to what this patient is having, ischemic versus non-ischemic. Then you would employ both these techniques to further elucidate what else this patient is having. So primary to the diagnosis of this young person's heart failure is the ejection fraction that we talked about. And as we know, the ejection fractions are different and they have different connotations in terms of prognosis, and also, like we know, in terms of treatment. So while echo is the central point for a heart failure patient's journey, once it is done, it's important to have a gold standard in terms of ejection fraction to make sure that any improvement based on your 4-drug therapy or the Fabulous 4 or any other therapy, whether it's CRT, will now be based on something which is the inter-observer variation is low. It's a windowless system of imaging, and you get a very good ejection fraction, volumetry, and also the mass. So this is a good an important gold standard before embarking on specific therapy for heart failure. And MRI is a very good tool, and this sequence can be done in about 10 minutes. It doesn't employ contrast and can be done very quickly and efficiently. And if you look at the recommendations, irrespective of the ejection fraction of these patients from mild, moderate to severe, CMR is the gold standard tool. And whether you've had an ischemic heart disease, MI, LV dysfunction, or if it is a non-ischemic, MRI has a very appropriate use in terms of quantification of LV function as well as volumetry. The second thing that we want to see in heart failure is whether this patient has a coronary artery disease or not. And this has traditionally been done by the angiography. And if you look at Felker's data, you will see that the ischemic subsets always fared worse whenever they were the cause of heart failure. And because of this, traditionally we have been using the coronary angiogram. You can see the normal angiogram on the left, and here there is an LAD occlusion, as a means to ascertain whether this patient who's come with a severe LV dysfunction global hypokinesia has an underlying CAD or not. But what we have also discovered over the years is that the cardiac MRI, not only being an important point for volumetry ejection fraction, also has a means to tell us what the underlying basis of heart failure is for this patient. And if you look at the orange arrow above, you will see the very typical subendocardial delayed enhancement, which is there both in the inferior septum as well as the basal anterolateral wall, compared to the next patient, which is the mustard arrow. You will see that the scar here is actually mid-myocardial, and there is a space between both aspects of the scar, suggesting that there is no vascular etiology in this patient with heart failure. And the third type of patient is a patient who has what is called a subepicardial kind of scar, especially involving the infralateral wall, and usually seen in younger patients after a typical viral syndrome, and we saw a lot of this during COVID, which is suggestive of myocarditis. So without resorting to an angiogram, by the use of MRI, you can have a fair idea about the underlying cause of the heart failure. And now what we are doing is we are employing what is called a T1 mapping sequence. So single stain, no contrast, you get what is called T1 maps. And based on the disease, the T1 and the ECV, you get a whole host of diseases that can be looked at in heart failure, starting from iron overload patients right up to patients with amyloidosis, myocarditis, infarction, and even the hypertrophic cardiomyopathy group of patients based on their T1 values. And this does not employ using contrast again, can be done in 10 minutes. And then you have a good idea about the diffuse fibrosis which is there in these patients. So going forward, when you want to look at which technique is the gatekeeper, you have the echo tools, the SPECT and MRI, which have to be used in these kind of patients with severe LV dysfunction because of their high perioperative risk before you take them to the cath lab or intervene in terms of PCI or CABG. And all three techniques are good techniques, and all three techniques in the right hands, in the right institution, have a certain amount of validity. So we'll be just looking at some of them, and you will see that the echo techniques here have a very high degree of contractile reserve assessment and tissue volume loss, not to mention their easy availability, cost, bedside availability. The nuclear techniques again are very strong with metabolic, perfusion and membrane transport. And if you look at the MRI, it encompasses a lot of the echo features and nuclear features and seems to be a complete solution, although expensive and not freely available. So not only ejection fraction, which is important to classify these patients, we use echo for risk assessment, we use them for quantification of regurgitation, we use them for the assessment of diastolic function, the left atrial volume, especially in patients with HFpEF, and the RV, as we've seen, for looking at the right-sided disorders, and also for assessing patients who require a CRTT device. And when we follow these patients on echo, we will see the volume start dilating, the mitral regurgitation starts getting severe, and then they need to be intervened. So when you look at the dobutamine versus cardiac MRI, you will see that the dobutamine looks at the contractile reserve, dysfunctional segments, and the contractile reserve. However, in patients with pre-existing diseases, already thin walls, it can be a little difficult to demonstrate that slight improvement, and therefore, although the specificity is excellent, there is a little lower sensitivity. And sometimes with our obese patients, the acoustic window becomes an issue and the lower spatial resolution. When you look at the nuclear techniques, we have a very clear-cut plan as to how to look at their viability. And when we see the uptake more than 50%, we know they're clearly viable. Anything less than 30% is non-viable. And when you add nitroglycerin to these patients sublingually, they become as good as thallium or nearly as good as the PET FDG. But it is in the 31 to 50% patients, we really struggle to assess whether they're really viable or not. And what we do in our lab, because these are all gated techniques, we use technetium sestimate. We look for wall thickening in these patients. So if it is present, these are viable, and if not, they are non-viable. But this is definitely a gray area,
And you will clearly see here, when we're looking for subendocardial scars, the nuclear technique which is below is definitely inferior compared to what the MRI can show, the subendocardial scars. Here the nuclear technique is almost normal, so subendocardial scar assessment becomes a problem. And again, when you're looking for patients with multi-vessel issues, the nuclear technique, especially if we use adenosine in little sicker patients who can't walk, you can clearly demonstrate the ischemia. Here we are able to demonstrate the RCA ischemia here and the LAD ischemia here, all in one patient. So many times if you're judicious in using the technique, you can even cover up triple vessel disease, which sometimes can be a Achilles heel in this technique. Moving on to the PET scan, and we know that if the PET scan shows a mismatch defect, that means there is decreased perfusion, but there is presence of FDG or metabolism, and this mismatch defect is the patient who is going to benefit maximum from revascularization. So the PET and MR data is very, very similar, and the true positives, true negatives are again extremely similar. But if you look at the spatial resolution again, you will find, compared to the PET and the MRI, the tiny subendocardial scars here, which are actually very good for revascularization, are not even seen on the PET. CTA is the new customer on the block for looking at viability and heart failure. And number one, you get to see the coronaries, which is an important thing for our patients because we want to know if there's coronary disease or not. But we're also able to look at scar now by doing delayed imaging, as you can see here. You have to wait for 6 minutes after a routine CT, and you will be able to assess the scar, and the scar burden spatial resolution is almost as good as MRI. The only problem is you have to do 2 scans, and that adds to the radiation burden. In patients with CTOs, again CT is very valuable because it not only tells you the lesion, but also tells you the distal vessel below that. And what we use is a CT Rector score, which tells us how easy or how difficult this CTO evaluation is going to be. And then if you add the viability to the CTO, then you really know how much benefit you're going to get. We are moving into hybrid imaging, and SPEC CT is becoming commonplace in most of the metros now, where we are able to look at the coronaries like in this patient, and also we inject technetium, and we are able to get both the ischemia in the right coronary, and we are also able to get the occluded vessel and the vessel distal to it. So hybrid imaging is coming in a big way. The big problem obviously is the lack of large amounts of data which echo and MR have, and radiation is a problem. But again, with higher end CT scan, the sub-millisievert or near sub-millisievert radiation is coming into the picture. Obviously, we have to give iodinated contrast, and that could be an issue with both patients with renal and cardiac impairment. So finally, this young person had an angio, and as you've seen, it was a normal angiogram, and this was what this was what his MR looked like. So dilated heart, dilated LA, there is a moderate mitral regurgitation which is central, suggesting that this is more of a secondary mitral regurgitation. And if you look at the screen on the right, you will see that there is absolutely no scar. The myocardium is pristine black, and that's very, very important for prognosis. The other thing that we do before putting this patient on medication is doing the genetic testing, and we do that for all patients who have a family history of DCM, family history of sudden cardiac death, or somebody with a rare genetic disease, or somebody with a severe kind of phenotype which has a sporadic DCM. And we do that for the index patient and the children of the patient who are more than 10 years of old, or siblings. So we have a center in Hyderabad, CCMB, where we send our patients, and we get a certain amount of the genetic panel is sent, and then we get the sequences if they're important. And there are a couple of patients whom they're all negative, and of course they're just kept on medical management. So I will stop here and just tell you that the management again is based on both the lifestyle, which is important, and the Fab4 drugs, and looking also at the precipitating causes before you start treating them. I'll stop at this point. Thank you.